In today's lecture, I'll be discussing how to ventilate COVID-19 patients. This discussion is based on a lecture that was published on a webinar from European Society of Intensive Care Medicine on April 2nd. So it'll be based on a 40-minute discussion, and I'll be trying to concise it in less than 10 minutes. Thank you to Dr. Comparada, that was the one that gave this lecture. So to start with, I know that essentially from all the publications that I posted, you are aware that there are two different spectrums, or there's a spectrum that exists with patients who have COVID-19. They either have a phenotype L or a phenotype H. And looking at this diagram here, you could see that initially patients with hypoxemia, it's either due to dysregulation of pulmonary perfusion that it could cause pulmonary microthrombosis, which is why we see a lot of patients with microthrombi manifesting in either pulmonary embolisms or DVTs, essentially venous thromboembolisms. You could also see patients with pulmonary edema collapse that appears like ARDS-like. And the way that this author named ARDS-like has a specific pathophysiology that I'll explain later. But in general, patients with phenotype L is, as you could think of L as low elastase, low VQ, mismatch, low recruitability, and limited PEEP response. And the phenotype H is essentially high lung elastase. And elastase is the amount of work that it takes to be able to recruit lung alveoli. So you could also think of it as the opposite of compliance. So patients with high lung elastase have low compliance. They have higher recruitability. They have higher right to L shunt, and they also have higher PEEP response. That's phenotype H. And it could exist in a spectrum. Patients might present initially with phenotype L, and then they develop phenotype H during the course of their disease. And the reason why the author called it ARDS-like is because, as you're aware from the images that I posted on my Instagram, you also notice that some patients might present with really diffuse bilateral infiltrates, pulmonary edema. Obviously, it looks consistent with ARDS, but oftentimes there's a spectrum of severity to those lung x-rays. Also on CT scan, you could see a patient with ground glass opacities to the left here, but then on the right, you see patients with a pretty diffuse consolidation bilaterally, more significant of an ARDS-like picture. So the author actually called it more of patients on the left with a ground glass consisting more of a COVID-19 pneumonitis versus an ARDS-like picture. So that's essentially what the author was focusing on during that lecture. He also mentioned that phenotype L's and H, even though they might have the same PF ratio, obviously on CT imaging, they have pretty different variation and compliance. And as a result, you could see those significant changes on the CT scan with patients having ground glass on phenotype L to phenotype H having pretty focal consolidations bilaterally. So obviously, given those CT imaging, you would think that they would behave differently when they become mechanically ventilated. And obviously, research does show that that's the case. And the reason why he also believed that the Berlin definition of ARDS for these patients might not exactly fit is because some patients have a hyperacute phase in which they do present within less than 1 week. But other times, these patients could also come in with a clinical insult that is biphasic, essentially saying that it might take them longer than 1 week to fully present in an ARDS-like state. And on chest imaging is not typically always bilateral opacities. Sometimes they could have focal consolidations. But the other fourth origin of edema, oxygenation, those are very consistent of ARDS. So based on that, he said the Berlin definition doesn't fit exactly of it for ARDS in these COVID patients. So COVID-19 pneumonitis isn't exactly ARDS based on his definition. And in the next following slides, I'm going to describe to you kind of the workup that he recommends or the algorithm of managing these patients when they hit the floor. So what he looks at is assessing the shunt fraction, essentially asking how severe is the hypoxemia, assessing the risk of having patient self-induced lung injury, and also phenotype screening. Now that they're mechanically ventilated, what's the phenotype definition? Is it phenotype L or H? because if they're based on what they are, the management would be different. And then when most if mechanical ventilation management fails, what then are your next options? That's something that I'll discuss also. So initially, when patients present, they're either hypoxemic, and we mentioned earlier what you would do in those cases. But for these patients, they might be requiring an FiO2 of greater than 40%, and there obviously is a ceiling for escalation if it's at 40%. But if patients have if they have FiO2 that's already maxed out, their ceiling of escalation is at the highest, obviously, then at that point, palliative care might be the best option for them, unfortunately. But also, in general, patients who do have more room to oxygenate, you need to ask yourself, what is the patient's work of breathing? Does the patient have a significant work of breathing, or is it low? And then the next slide, I'll help you kind of understand what he meant by that. The way that he defines hypoxemia, assessing hypoxemia, is based on shunt fraction. So patients in which what he looks at is acceptable range of saturation will be greater than 95%. If, for instance, they're on nasal cannula and they're getting up to 10 liters and their oxygenation is not going up even after you bump it all the way high, even if FiO2 is going higher, if they are up 60% or 80% and there's barely any significant difference, then the patients have a significant shunt fraction. So if you know what a shunt is, essentially it's alveoli that are completely collapsed. So no matter how much oxygen they get, they will not be able to perfuse their organs, and as the result, they're still hypoxemic. And for those patients, they're categorized as severe shunt fraction or severe hypoxemia. And then the next thing you need to look at is you got to ask yourself, what is a respiratory drive? In what fashion does that exist? So patients could have respiratory drive in the form of metabolic drive if they're septic and they're having a lot of metabolic drive from that as a result of that. Or patients who are COVID-19 could be hypoxemic given essentially from a lot of stress and strain caused from inflammation. They could have a lot of pulmonary edema. Elastic workup breathing could be elevated. The respiratory rate could also be elevated. But something that's really interesting that the author discussed is that a lot of times some patients might not have subjective dyspnea. Even though you might see that they have intercostal breathing, they themselves don't feel anything. And that's because the virus, the SARS-CoV-2, affects the ACE2 receptors, in the midbrain. And he was saying that because of that, there is a cardiorespiratory issue in which the patients do not feel any subjective dyspnea. So a lot of times they might be really relaxed, they might be chilling, and all of a sudden they could crump. And so that's why it's important for you to really understand, based on exam, the respiratory rate of the patient. And that also explains what some patients have anosmia, which is they are not able to smell, and that's because it affects the midbrain as well. So what do you do for patients with hypoxemia? Then obviously you increase the FiO2, you improve VQ mismatch, like I mentioned. And what do you do for pulmonary edema? Then at the mechanical support, control respiratory rate through mechanical support or through obviously neuromuscular blockade of the patients, so you can control the respiratory rate. So what mode of ventilation do you use? So he said that for all this, it really depends on the considerations, the infection control. High flow nasal cannula could aerolize the virus, so that's a concern. Also, and depends on the support that's required, the duration of disease, and the resources. So in general, he mentioned how the biggest issue with non-invasive ventilation is that a lot of patients, there was an increase in mortality. This was based on studies prior to COVID-19. But he said that for invasive versus non-invasive ventilation, patients with moderate to severe PF ratios, in the non-invasive group, there was actually significant mortality or survival in those patients. And he attributed it mostly to the time of intubation. The intubation rate was obviously higher for non-invasive patients, but oftentimes what would happen is that the delay in intubating these patients was greater. So that's why there was a higher risk of mortality in non-invasive groups. And he also looked at literature that looked at high tidal volumes during non-invasive And he was also citing literature that looked at high tidal volumes greater than 9 mLs per kilogram were actually associated with a greater amount of ventilation-induced lung injury, and as a result, greater increase in mortality. So in general, what he looked at was this circle or cycle. Essentially, patients would have impaired gas exchange from a decrease or increased lung elastase, work of breathing. As a result, they would obviously have decreased compliance, and they're going to have an increased respiratory drive because they're not able to ventilate well. And as a result of this increased respiratory drive, they're going to have increased tidal volumes, and they're going to have self-induced lung injury because of that. And there's going to have capillary leak, capillary edema. So it's an ongoing cycle of lung injury as well. So a good understanding of this disease course and late failures will be able to help us kind of stop this cycle by intervening at the right moment. So you have to understand that some patients, there is a spectrum of disease, obviously, like we looked at, but there's also a disease course that we need to understand. Is some patients could so it is during this disease course that we need to kind of understand. So there's some patients, their patients could present in the couple days with hyperacute, and during that time they might need immediate intubation because they have severe hypoxemia and increased respiratory drive. Or there could be you could have some patients who are lucky and they present indolent. They have an indolent course in which they have moderate or severe hypoxemia, but only moderate work of breathing. And those patients could be potentially be trialed on non-invasive ventilation. But then you have to also be aware of these biphasic patients in which they have an initial indolent course followed typically after 5 to 7 days by an acute decompensation. They have hyperinflammation, the ferritin, all the inflammatory markers are going to be elevated, and they're going to start having a cytokine storm response. In those patients, it's important to not delay intubation. And because if you delay intubation, you're going to have an increased mortality for those patients. So how do you manage those patients? So once you understand, okay, these patients, you trial them on non-invasive ventilation or just high flow nasal cannula, and they are decompensating you, their respiratory drive is high, you could see that there is a pretty significant chance that they are going to crump, then at that point you would intubate them. So the author also has this diagram in which he looks at specific markers. You want to keep a tidal volume of 8 cc's per kilogram per ideal body weight. And then you look at the driving pressure, and driving pressure is the difference between the plateau pressure and the PEEP. So essentially, it's calculating the amount of work to open up an alveoli. And if a patient has a really high plateau pressure, then that's telling you that the patient also has a pretty poor compliance. So you want to keep the tidal volume at 8 cc's, but if the patient, if it's less than 15, which is good, if it's greater than 15, then you could reduce the tidal volume to 6 cc's per kilogram to be able to decrease the driving pressure. And then after you see that and the patient's still not improving, the patient's still desatting less than 90 with FiO2 greater than 70%, then at that point you could consider neuromuscular blockade. You could increase the PEEP up to 15. And then at that point, if they still continue to desaturate, then it's no matter what, I think it's always important to look at the compliance. But what he was mentioning was if the compliance of the patient is, there's calculators you can use to calculate this, by the way. So the compliance is greater than 40 at that point, then the first strategy would be prone positioning. You could use same ventilatory settings as the above. And really what we're treating for these patients is we're treating them as like phenotype L with low elastase, which means high compliance, prone responsive. And so that's kind of the first strategy method that you will use. And obviously there is a spectrum. So patients who could develop really worsening lung inflammation could have a pretty poor compliance system. So if you were to find them having a very poor compliance system of like less than 40, so then if the patient has a pretty poor compliance, which means the less than 40, then you could consider using an airway pressure release ventilation method of ventilating the patients, which essentially is a pressure control mode of ventilation that helps kind of gives a continuous positive airway pressure at a set interval timing of things. So it releases the applied pressure at a specific amount of time. It's very important in these patients who have low compliance systems because you want to further reduce the risk of having ventilation-induced lung injury, and that's what the system is used for. It's more of a lung protective strategy you can use. So finally, in the end, if patients are still refractory to all those interventions, including prone positional or a PRV for greater than 6 hours, then at that point it's probably important to consider ECMO for these patients. And we don't have enough data to look at the mortality benefit of starting ECMO. That's still ongoing research at this point, but really that's really the end of the line treatment in terms of interventions for these patients. So in summary, the most important thing is you want to recognize patients who are in the hyperacute phase because they need immediate intubation, and they're also high risk for cardiovascular events, obviously cardiac arrest, given their severe hypoxemia. And you also patients who are who are not in the hyperacute phase and they're hemodynamically stable. It would be okay for you to do a trial of non-invasive ventilation with CPAP, given if they are able to tolerate it because they have low respiratory drive and low inflammatory markers. But you also want to consider the idea that they could also be in a biphasic course in which they have an indwelling course now, but they could still have a severe acute inflammatory response leading to severe ARDS. And it's also important to differentiate patients who are mechanically ventilated from L-type phenotype or an H-type phenotype in which they have a low compliance system, because it's important to be able to understand the different management for these patients. And finally, understand that patients who have COVID-19 might have COVID-19 pneumonitis, and as a result, you should not just throw at the kitchen sink and treat them like ARDS. You need to understand the physiology to be able to help these patients. Hope that it made sense. I'll catch if you guys have any questions. You could always comment or message me directly. I'd love to help you guys understand this. Obviously, I'm still learning, so shoot me any questions, and I might be learning a lot more from you guys than you are learning from me. So I really appreciate it. Thank you.